All right, guys, so this is going to be chapter 15, the thorax and lungs. We've got a focused assessment that's coming up later on in this class as well, so we're really going to go over a few things that probably should be pretty familiar, but they're going to play into the more advanced topics that we'll get into later on. All right, so jumping right in, we have the anatomy and physiology of the chest wall. So when we start to assess our patients, there's so much information that we can see just from really, that thoracic cavity and up, okay? So what are the anatomical boundaries that we're looking at when we're talking about the chest wall? So the thorax is going to be bordered by the sternum and ribs anteriorly, okay? And the thoracic spine posteriorly. All right, the clavicles and neck tissue superiorly, and then the diaphragm inferiorly, okay? So we know that the chest wall contains the lungs and heart, all right, providing protection and mechanical power for respiration. So there's, a lot of motion that comes from the movement of this rib cage that allows us to breathe, that helps with venous return. There's all kinds of added benefits. All right, so the chest wall is going to be comprised of the ribs, intercostal spaces, and the diaphragm, which are going to be integral to the mechanics of breathing. All right. When we start to talk about finding things on the chest, all right, so there's certain anatomical landmarks that are going to be very important that you guys are familiar with and that you're able to identify on your patients, especially when we start talking about the point-of-care ultrasound. So the xiphoid process will be a big one, all right. Obviously the sternum. Then we have our intercostal spaces, so knowing where your second rib is and your second intercostal space, the sternal angle, all right, suprasternal notch. All of these are going to be extremely important to remember and to know how to identify these, okay? Okay, so if we start looking at the ribs individually, okay, we have 12 ribs, all right, and there's some very important procedural landmarks that you guys need to remember, specifically knowing where that second intercostal space is and the midclavicular line. Okay, that's where our needle insertion site for attention pneumo is going to be. I don't know if any of you guys have ever had to do that, but there's a lot of trauma people that say somebody's not actually dead until they have a needle in each second intercostal space, just to ensure that they don't have attention pneumo. All right, so definitely remember that. Our fourth to fifth intercostal space is going to be our chest tube insertion site. We'll talk about there's a window of safety as far as avoiding vascular structures and lung tissue that comes later on in this lecture. The fourth rib level is a lower margin for proper placement of the endotracheal tube on a chest x-ray. So if we were looking at an endotracheal tube coming down, the carina should be somewhere around here. So we're really looking for the ET tube to be positioned somewhere in that area. Also, when we start to think about how our neural structures course through these ribs, okay, so how do all of these little tiny arteries and nerves come along here? They're going to run the inferior margin of each rib, so along the bottom here. So needles and tubes should be placed at the superior margin of a rib to avoid injury. So if we're looking at this intercostal space, we want to come off the top of these ribs if we're going to try to access the thoracic cavity. Okay? So as we know, not only do we have an anterior side to assess of the thoracic cavity, but we also have the posterior side. So definitely some prominent landmarks that we need to remember on the posterior side to be able to assess our patients. So the inferior tip of the scapula is going to align with the level of the seventh rib or seventh intercostal space. C7 spinous process is the most prominent spinous process when the neck is flexed forward. Okay, if they're two equally prominent, they're usually C7 and T1. All right, so that's a good way to be able to identify where your vertebrae are at. And then along the spinous processes, you can use counting for them along the spine, particularly when the spine is flexed. This is aiding in locating and counting your vertebrae. So We can also use this when we start to talk about ESP blocks. You're going to start counting these posterior spinous processes, look for this transverse process, and we'll be trying to find this area right here where that rib is joining that transverse process. So just becoming familiar with the anatomy and the way that these bones interact is definitely going to be important for further assessment and further procedural skills. So as you all know, when we talk about things medically, we always use some sort of locating or descriptors that help us communicate where something is on the human body, right? So we have several different lines that are used to divide up the thoracic cavity. The mid-sternal line runs down the middle of the sternum. The mid-clavicular line, I would definitely be able to identify that one. That would be an easy hotspot question. Anterior axillary line, mid-axillary line, posterior axillary line, scapular line, and vertebral line. So I actually have all these on the next slide with the pictures from your text. So you can see your vertebral line, scapular line. Here's your mid-sternal, mid-clavicular, anterior axillary. And then we start to talk about on the side of our thoracic cavity, so anterior axillary, mid-axillary line, and posterior axillary line. So all these are used to describe things, whether it be in findings from x-rays or when you're describing something to, say, somebody you're doing a procedure with. So earlier I mentioned a triangle of safety, okay? It's located in the mid-axillary line, so that would be this guy here, right? So we come down, it's formed by the lateral border of the pec major anteriorly, so lateral border of the pec major, okay? The lateral border of the latissimus dorsi, which is your lat. So if we think about, okay, this comes in here, all right? And the nipple line, which is usually your fourth or fifth intercostal space, so think about that right there. All right. This is marking a safe area for chest tube insertion. So if you think about where your pleural tubes were normally, they generally were somewhere in this location over here. Sometimes you would, for cardiothoracic surgery, it's a little different, but if we had somebody that had a pneumothorax, a lot of times that chest tubes can be placed over here. All right. So let's talk about some lungs, fissures, and lobes of the lungs, all right? As you can see here, you got a chest x-ray of a patient, and we can see the different lobes of the lungs described here and outlined and highlighted. I think this is a great picture to kind of commit to memory. That not only is going to allow you to assess your chest x-rays of your patients a lot better, but be able to describe to whoever you're working with or to the surgeon, what is going on with your patient. And we'll get a little bit further into this, but learning how to discern what is what on these chest x-rays is going to be super important. All right, so obviously you guys have studied anatomically the lungs, but let's review a little bit of the anatomy. So the apex of each lung is going to extend 2 to 4 centimeters above the inner third of the clavicle anteriorly. Okay, this is why we don't want to get too far down when we're scanning for, our brachial plexus blocks, when we're looking at, starting a central venous catheter, anything like that. We have to remember how close these lungs get to some of the regional anesthesia procedures that we do, and also to the central lines that we place. So definitely important to remember that. The lower border of the lungs is going to cross the 6th rib at the mid-clavicular line and the 8th rib at the mid-axillary line. So if we think about that, mid-clavicular line comes down, and it's just showing that shape of the lung, and then at the 8th. So here's our 6th, and then we come down to the 8th on our mid-axillary line where they wrap around. So posteriorly, the lower lung border lies at the level of T10 in the spinous process during rest. All right. On inspiration, the lower border descends further due to diaphragmatic excursion, all right, or diaphragm contraction. So when we start to think about the division of our lungs into lobes, these fissures are what cause that to happen. So each lung has an oblique fissure that courses, usually extended from T3 down to the 6th rib, okay, at the mid-clavicular line. So it wraps around on both of these. And then on our right lung, we have an additional horizontal fissure running near the 4th rib anteriorly and meeting the oblique fissure near the 5th rib in the mid-axillary line. So that's this guy right here. All right. So I would definitely be able to label right upper lobe, right middle lobe, right lower lobe. That should be pretty easy, but easy question there as well. All right. So we just talked about the right lung consists of 3 lobes: right upper lobe, right middle lobe, and the right lower lobe. The left lung is going to consist of 2 lobes: the left upper lobe, the left lower lobe. Lung fissures and lobes can be visualized on chest radiographs with clear differentiation of lobes and figures. All right, the anatomical borders and fissures are crucial for understanding lung structure and interpreting imaging. So let's look at it overlaid here. All right, so this is a nice image that's going to show your right upper lobe. The only thing is the image is kind of rotated, if we think about it. So this patient's facing appropriately, but we have posterior spine here and spine here. But we have the right upper lobe. We have this horizontal fissure coming across. The oblique fissure comes through here, just like you see on the picture, in your right lower lobe. All right, and same goes for the left side. Left side comes up, just like so. You can see that oblique fissure separating our upper and our lower. All right, so the tracheobronchial tree. You guys probably have reviewed this pretty extensively in your anatomy course, but we're going to review just a little bit here as well. So the trachea bifurcates at the sternal angle. So if you go back to our anatomical landmarks, it's going to be important to remember that. And T4 spinous processes posteriorly into the right and left main bronchi. Okay, so the right versus left bronchus. The right main bronchus is wider, shorter, and more vertical, okay, entering the lung hilum directly, while the left main bronchus extends inferior laterally, passing below the aortic arch and anterior to the esophagus and thoracic aorta. So we know that this information right here for the right bronchi, you really, this is the why behind, most of the time when we have an aspiration event, our patients have consolidation and issues with the right lung primarily. All right. So breath sounds over the trachea and bronchi are going to be harsher than those over the long parenchyma. Okay. So when we think about breath sounds, there's a reason that we hear a difference in the flow of that air. All right. So then, what are the Reynolds numbers that are going to be associated with the flow and the breath sounds that we're hearing? So this is pretty interesting. If you look in the notes, you go back to applied sciences, and we have different types of flow, right? Laminar, turbulent, and transitional, right? So the tracheobronchial tree contains all three. When we think about the trachea, it has a large diameter. It's going to have a high airflow velocity, leading to higher Reynolds numbers, so 2,000 to 3,000 or higher, which is going to be consistent with a transitional or turbulent flow, okay, depending on how hard the patient is ventilating. When we get to the main stem bronchi, they're going to branch off. The diameter is going to decrease, but flow still remaining pretty high. So we're going to stay in that transitional flow area, 1,500 to 2,000. Then we get into the lobar and segmental bronchi. We're starting to really decrease in diameter, lowering those Reynolds numbers down, so it's really starting to sound like a smoother flow, right? And then we get into the respiratory bronchus, respiratory divisions, and this is where we're starting to get gas exchange, and it really slows down and becomes laminar there. It sounds really smooth. So this is, it's the why behind what we're hearing. So when we think about the gas exchange pathway, our main bronchi divide into lobar bronchi, segmental bronchi, and the bronchioles terminating in alveoli where gas exchange occurs. So how many divisions does our airway go through in total? Okay, so that's going to be 23. All right, 23 divisions in total. And then at what division does gas exchange begin to occur? That's typically going to be around the 17th division. Okay, so clinical implications, when we talk about really the biggest thing is the right main stem bronchi or bronchus is going to be wider, shorter, and more vertical, allowing whatever aspirate is coming down through the airway to go straight into the lung. Okay, it also what leads to a right main stem intubation. That's why we need to make sure we're listening to our breath sounds. All right, so this is a good illustration to show you the difference between your right and left main bronchus. If we look here, trachea comes down, we have the carina right here, and then look how short the right main is and how steep it is. Okay, and then our left main angle is not nearly as severe and it's much longer. So this leads to less aspiration in the left lung, and this right lower lobe is just like a chute straight down into it. When we think about aspiration events, usually you see that right lower lobe and this right side just get affected much more than your left side. All right, so everybody studied what the pleural surfaces are that we have. I'm sure you reviewed this in anatomy, but how does this relate to our assessment? Really, when we start doing the point-of-care ultrasound, when we start the focused assessment, this is going to be huge because this is how we tell if our patient has a pneumothorax, if they have normal lung pathology or not. So let's get into some of the anatomical review. All right, so the visceral pleura is going to cover the outer surface of the lungs. Okay, the parietal pleura lines the pleural cavity, including the inner rib cage and the diaphragm. All right, so the pleural space is between the visceral and parietal pleura and contains serous pleural fluid, okay? So the surface tension of the pleural fluid is what maintains lung contact with the thoracic wall, enabling expansion and contraction during respiration. The visceral pleura lacks sensory nerves, while the parietal pleura is innervated by intercostal and phrenic nerves. So if we don't have the correct amount of pleural fluid, or if we have too much, or we have something that disrupts these pleuras, these pleural surfaces, that's where we start to see inflammation. That's where we see a decrease in our respiratory capacity of our patients. And these two pleural surfaces sliding back and forth is what we're really going to be assessing when we're looking at our patients with ultrasound, okay? And we'll get into this in the end of this course when we go into our focused assessment. But on the next slide, we'll review just a few of the basics here. So if we hit this link here, it's going to link you to the pleural side of that course on butterfly. Like I said, this is just a brief review. I don't expect you to know this for this exam, but if you want to go ahead and start looking at some of this stuff when we start to do these assessments in the class, this will help you drastically. All right, so breathing seems like simple, easy process, but it's actually, a very dynamic movement that a lot of different muscles are actually playing a role in. So obviously we know that breathing is primarily automatic, right? We don't have to wake up every 10 seconds to breathe while we're asleep. It's controlled by the respiratory centers in our brain stem. The diaphragm is going to be the principal muscle of inspiration, contracting and descending and to expand the thoracic cavity. So remember, when that muscle contracts, it expands that thoracic cavity, drawing negative pressure. So we decrease the pressure inside. The atmospheric pressure pushes the air down into our lungs, and that's how we normally breathe, with negative pressure respiration. So it changes when we anesthetize the patients and we're talking about positive pressure ventilation, right? So inspiration is going to involve the scalene muscles, which attached somewhere around the cervical vertebrae and the first two ribs, and then the parasternal intercostal muscles, which are sternum to ribs, and this helps open up that rib cage to allow our lungs to fully expand. Okay, this is also when we start seeing really, patients that are breathing heavily. They start to use those accessory muscles, and we start to see more use of muscles that aren't used in just normal respiration. So expansion of the thorax is going to decrease intrathoracic pressure, like I was saying, drawing air into the alveoli for gas exchange. Oxygen diffuses into pulmonary capillaries while the carbon dioxide exchanges into the alveoli. That's basic stuff that you guys reviewed in anatomy. So during expiration, the diaphragm is going to relax and rise back up into the thoracic cavity, and the chest wall and lungs recoil, okay, assisted by the abdominal muscles. So normal breathing is going to be quiet with subtle thoracic movement when supine, but more prominent thoracic movements when sitting. The abdominal movements during breathing are more noticeable in the supine position. So that's when we see our patients seesawing back and forth, and we see those abdominal movements, and they're really like a belly breather. You hear that? That exhalation and abdominal movements really can cause, quite a bit of movement when your patient's laying flat. It's pretty noticeable. Like during colonoscopies, you can actually see the whole camera moving when they're trying to do the colonoscopy because the patient is literally breathing that hard. So accessory muscles like the sternocleidomastoid and scalenes are recruited during exercise or respiratory distress. All right, I would definitely know that. Like on the next slide, there's a description of, or a picture of the actual muscles. I would know which muscles we're going to use as far as what accessory muscles are. We're also going to review these for several of our different blocks as far as the anatomical position of everything. So breathing movements are going to adapt to posture with thoracic and abdominal patterns shifting between supine and sitting positions. So these are those accessory muscles. All right. So we have the sternocleidomastoid muscle that you can see here, the clavicular head and your sternal head here. All right. And then our scalene muscles are here, and the interscalene block is literally called an interscalene block because it's in between our scalene muscles. So we'll really start to review the anatomy of these muscles when we start talking about our regional anesthesia and brachial plexus blocks. All right, so anytime we have a patient, we need to get a pulmonary health history, right? This is probably one of the more dynamic, it's right in there along with cardiac on assessing your patient for their pulmonary health history, because not only do patients neglect their cardiac health, they also neglect their pulmonary health, as we've seen, people smoking, severe COPD, not seeing a pulmonologist, not using their breathing treatments, having sleep apnea, not wearing a CPAP at home, all the above. So here are a few things that we can kind of make sure that we cover throughout your pulmonary history when you assess these patients. So symptoms of thoracic and lung disorders are going to be common reasons for healthcare visits and can indicate life-threatening conditions requiring prompt attention. All right, so red flags that we need to recognize. Inability to speak in full sentences. So if you've ever been assessing a patient and they have to stop about every 3 or 4 words and catch their breath, they're very, very out of breath and in respiratory distress. If they can't talk at all, then that's even worse, right? Use of those accessory muscles that we were talking about, cyanosis, especially circumoral cyanosis. You'll start to see that with people that are starting to become hypoxic. They're really working hard to breathe. You've probably seen it if you've had a patient desaturate. They start to get that blue, purple hue around their mouth, and their lips kind of turn that dark red/purple color. If you start seeing this on a patient that you're assessing before you're going back to the OR, these are some really, really ominous signs, right? Low O2 saturation. We know that can be a confounding result depending on if the patient has some sort of pathological, process going on, methemoglobinemia, carbon monoxide poisoning. All these things can change that. And then pulsus paradoxus, which is going to be an abnormal decrease in our blood pressure during inspiration. So typically we see that in our pulse oximetry. We see that pulse variation in the pulse ox with inspiration and expiration. Usually that's a very good sign that the patient has some sort of issue with preload, whether that be that they're dry or they're having a problem getting that venous return and that preload into the LV. Okay? All right. So all of these things are definitely ominous signs, right? Chief complaint. So we're going to allow patients to describe their symptoms in their own words, focusing on the impact of position, environmental exposures, and symptom effects on functional capacity. That's a big one, okay? We start talking about metabolic equivalence in our cardiac lecture. I cannot stress to you how important it is that we understand the functional capacity of your patient, because that shows us their pulmonary and cardiac reserve. Can the patient, walk across the house? Can they cook without getting out of breath? Can they get dressed without getting out of breath? And we'll delve into what each metabolic equivalent is equal to. But if somebody can't sit up or can't move, so say you're moving the patient over from the stretcher to the OR table, and they get out of breath just from doing that, they have a very poor reserve, right? So not only are we listening to these patients, but we're watching, do they get up and go to the bathroom to empty their bladder before surgery? Are they able to walk, the 10, 15 feet from the bed to the bathroom without getting short of breath? How hard are they breathing from that minimal activity? All right, so obviously respiratory symptoms can stem from cardiovascular, hematologic, and other systemic disorders, so we have to do a complete health history, right? We can have LV failure leading to pulmonary hypertension, leading to RV failure, right? It's a connected circuit. So anytime we have congestion in one area, it's going to back up and affect the other. We all know this. You saw your patients that had severe LV failure that went into acute RV failure and had pulmonary issues due to the lack of blood flow through the pulmonary vasculature. So really, making sure that we're taking in everything as a whole and associating, does their long-standing COPD or emphysema, how's that affecting their heart? Because most of the time, if we have somebody with severe COPD and they've had these elevated pulmonary pressures and issues with ventilation, they're going to have issues with their heart as well. So it kind of one leads to another, right? Like I just said, comprehensive history. So we're going to obtain a thorough past medical history documenting medications, allergies, and any prior pulmonary or systemic conditions. A big one with your pulm stuff is if you start to get somebody that's had several pulmonary procedures, say they've had VATS in the past, they've had, blebs taken out of their lungs, whatever it may be, we need to ensure that we know where that's at, if it causes them any issues, how long ago was the surgery, do they have active lung cancer? All of these things are going to be extremely important to understand in your assessment because they're going to play in to our anesthetic. All right. So social history importance, investigate tobacco and recreational drug use, occupational environmental exposures, and travel history. Okay, these are critical in evaluating pulmonary diseases. So definitely smoking. We try to at least get the patient to not smoke the day of surgery. If not, we need to make sure that we document that. Recreational drug use, do they use drugs? Specifically, are they huffing anything? They're using like any sort of inhalants that can cause severe pulmonary irritation. It's something to be very cautious of because that can cause the lung tissue to actually erode and you end up with a spontaneous pneumothorax. So we switch from their negative inspiration and respiratory drive to positive pressure ventilation, and then all of a sudden we pop their lung when we apply a peak pressure of 30, which would normally not cause any issues to a healthy lung. All right, so shortness of breath and wheezing. Dyspnea and wheezing are going to be common respiratory symptoms, so often they're signaling obstructive airway disease. So dyspnea and wheezing are obstructive, okay? Airway diseases and infections and cardiovascular conditions. Cough and hemoptysis, or a persistent cough or blood-streaked sputum. Hemoptysis may indicate infection, malignancy, or trauma to the respiratory tract. Chest pain may originate from the lungs, but it also overlaps with our cardiovascular causes. So anytime, obviously, that's the key word, right? That's how you get into the ED for free. Say that you have chest pain. Sleep-related symptoms. So daytime sleepiness, snoring, and disordered sleep can indicate obstructive sleep apnea or other sleep-related breathing disorders, which may significantly impact health. So when we have sleep apnea, CO2 rises because our patients become apneic, they desaturate. Pulmonary resistance increases because of that increased CO2. And hypoxia, it strains the RV. I've actually had patients go bradycardic and asystolic due to their sleep apnea. This is in the ICU at Vanderbilt when I was working there. I had a guy 2 afternoons in a row. He was taking a nap. I was in my other patient's room. I look up on the monitor. He becomes bradycardic. And then all of a sudden, from bradycardia to asystole, it was, had happened really, really quick. But they took this guy to cath lab and everything else, trying to figure out why he was doing that after his open heart. I think he had an aortic valve replacement. Couldn't find anything. The only thing that we could associate with it was that he was sleeping, he desaturated, and his sleep apnea caused him to go asystolic. All right, so back to the dyspnea and wheezing, shortness of breath and wheezing. When we talk about shortness of breath, it's an uncomfortable awareness of breathing that is disproportionate to exertion, okay? We're going to assess its severity by evaluating how it impacts the patient's daily activities, like we mentioned before, like climbing stairs, carrying in the groceries. We want to identify triggers, timing, and associated symptoms, okay? Because this can become important, because if it's a cardiac issue that causes the shortness of breath, then we know we have something going on major with their cardiac system. Whereas if it's a shortness of breath that then causes chest pain, it can be, the opposite. So here's a great table from the text that lists out some of the possible causes of dyspnea. I definitely would study a few of these. So left-sided heart failure, I would know that one. That's an easy one to ask a question over. COPD, it's extremely common that we have patients that have COPD, asthma, and then spontaneous pneumo, and an acute PE. I will ask a question on the test with the patient scenario regarding some of the listing characteristics about this, associated symptoms, the setting. I'll include, a lot of the information that's in this, but it's really important to be able to piece these things together because, recognizing that a patient is short of breath is the first effort, right? We have to identify the problem and then what is causing the problem. How can we treat the patient to ultimately be able to get them through this anesthetic safely? All right, so a lot of our patients obviously will come in with a cough. What's important about this is, have they had a recent upper or lower respiratory infection? Have they finished a course of antibiotics, especially for kids? When you start doing pediatrics, you're really looking for an elective procedure for them to be at about 6 weeks out from that and to have finished their antibiotics for sure before we do an elective procedure. But what is the duration of the cough been? Do they have a chronic cough? Is it subacute, 3 to 8 weeks, or acute, which less than 3 weeks? So some of the things for, associated with a chronic cough, asthma, GERD, chronic bronchitis, bronchiectasis. Also, when we look at the subacute, post-infectious cough, pertussis, acid reflux, or bacterial sinusitis. Acute, it's what we commonly think of, your viral infections, bronchitis, pneumonia, asthma, or smoking. Now, when we have somebody that has a productive cough, that changes the game, right? We know that they have loose sputum that could be troublesome, right? Depending on how thick it is, you could actually have it clog your airway. So it's extremely important that we ask and think about, okay, what kind of problem could this present intraoperatively? Are they going to plug off one of their bronchioles? Are they going to plug off an entire lung or the ET tube? This could lead to a very acute situation very quickly. So, seeing, if they cough something up, look at the consistency of it. If they don't, ask them. Say, how thick is it? How much are you coughing up? Has it gotten better or worse over the last few days? These are all going to allow you to identify potential things that you might want to do before you go back to the OR. All right, hemoptysis. So the definition of hemoptysis is blood coughed up from the lower respiratory tract, ranging it from blood-streaked sputum to large volumes of frank blood. All right, so for patients reporting hemoptysis, we want to quantify the volume of blood, note the setting and activity, and identify associated symptoms. So massive hemoptysis is considered more than 500 mLs in 24 hours or more than 100 mLs in 1 hour. This is life-threatening, Now, if you have a patient that is having massive hemoptysis like that, that's something that you're going to have to take into account and try to identify where the bleeding is coming from. This is where a double lumen tube or bronchial blocker comes into place, and we're able to block off that section of lung that's bleeding and hopefully ventilate the rest. All right, so common causes of hemoptysis are going to be bronchitis, malignancy, cystic fibrosis, and less frequently bronchiectasis, mitral stenosis, Goodpasture syndrome, granulomatosis, and polyangiitis. Okay, so obviously we have two different systems converging there, right? We have our GI and our respiratory system converging right around our upper airway, So common things that we need to do is confirm where the bleeding is coming from. So blood may originate from the nose, mouth, pharynx, or GI tract, and then get into the lungs, and they're coughing it up, right? So vomited blood typically is going to indicate GI origin. It is going to be darker and sometimes mixed with food particles. So if we have somebody that's vomiting up, coffee ground type blood, mixed with maybe some frank blood, we know that that's probably been in the stomach for a while, especially if it has food matter in there with it. So when we look at our different patient populations, hemoptysis is going to be very rare in infants, children, and adolescents. If we do see that in that population, it's usually very ominous. But regardless, hemoptysis carries a pretty severe outcome most of the time. When you start to see people coughing up, especially large amounts of blood, this can be very life-threatening very quickly. All right, so another good table from the book talking about your different types of coughs and sorts of inflammation that cause that cough and sputum. When we really look at these, this one's going to be important, identifying somebody that has a GERD that maybe is not diagnosed and doesn't have it controlled, because you're putting at a higher risk of aspiration with that. I definitely would know it. I would know laryngitis, TB, and LV failure. All right, so as we discussed earlier, another symptom that we have to kind of see through and diagnose is going to be chest pain. All right, obviously the big hit for chest pain is going to be your cardiac causes, but there's also other issues that can cause chest pain. It can originate from the lungs, thoracic structures, musculoskeletal system, extrathoracic organs like the esophagus, stomach, and gallbladder. Your most obvious cause, like we said, is going to be your cardiac, angina pectoris, MI, myocarditis, pericarditis, and other characteristic symptoms like the Levine sign, which is, like they have a grasping fist over top of their sternum, and it's just chest pain that's very central. Feels like an elephant sitting on my chest, that type of pain. Pulmonary causes pain is going to arise from the parietal pleura, inflammation in conditions like pneumonia, a PE, pleural effusion, pneumothorax, and connective tissue disease. Lung tissue itself lacks pain fibers, so we only receive that type of pain from the parietal pleura. We could also have an aortic dissection. Okay, this is obviously a life-threatening condition that causes sudden severe chest pain radiating to the back. And then there's esophageal causes, so pain from acid reflux, or esophageal spasms, or tears that may mimic cardiac arrest pain, often involving burning sensations or discomfort. So we can also have musculoskeletal causes of chest pain. Costochondritis and muscle strain from coughing can result in localized tenderness, often elicited by pressing on the chest wall, so make it worse if we press on the chest wall. Anxiety and panic disorders can lead to chest pain. Okay, it occurs in 1 of 4 patients with panic or anxiety disorders. This is often presenting with vague, diffuse discomfort, okay, and accompanied by all the symptoms of anxiety. Extrapulmonary sources, so pain can originate from cervical arthritis, biliary colic, or gastritis, mimicking thoracic or cardiac pain. We want to start with open-ended questions and observe patient gestures, so we'll see if they have a clenched fist for angina or pointing towards tender spots for musculoskeletal pain. Really, with any sort of pain, we want to look at the 7 attributes of pain, so the location, quality, severity, timing, setting, aggravating/relieving factors, and associated symptoms to distinguish among the different causes. So again, looking at these tables, they really list out some good information in a very brief format. So I would look at your MI, know it, pericarditis is another one, aortic dissection. Angina pectoris is another good one. I would know how to determine pleuritic pain, and then the others we'll cover in another chapter. So this is a big one, all right? Daytime sleepiness, snoring, and disordered sleep, okay? So this is all going to be leading towards obstructive sleep apnea or other sleep disorders. But common symptoms are going to be excessive daytime sleepiness, fatigue, snoring, witnessed apneas, okay, greater than 10 seconds. So that's a big one. If they have a family member in there that sleeps in the same room as them, have they witnessed that patient falling asleep and stop breathing for more than 10 seconds? Awakening with a choking sensation, okay, morning headaches are hallmark signs of disordered sleep, okay, because they're apneic for so long, they have a CO2 buildup, which leads to increased intracranial pressure. All right, so the key condition, all right, these symptoms often indicate obstructive sleep apnea, okay, particularly in individuals with obesity, retrognathia, or treatment-resistant hypertension, okay? Pay attention to these for sure, okay? That's an easy test question right there. Associated health risk for obstructive sleep apnea is going to be commonly linked to heart failure, atrial fibrillation, stroke, and type 2 diabetes, okay? Underlying mechanisms are going to include instability in the brainstem respiratory center, disordered sleep arousal, upper airway muscle dysfunction, so the genoglossus malfunction is the main muscle that we're talking about here, and airway collapse due to anatomical changes like obesity. All right, so the importance of evaluation. We want to thoroughly question our patients about sleep-related symptoms. It's going to be crucial for identifying OSA and associated conditions, and it can have significant cardiovascular and metabolic implications. All right, so when we start to talk about actually assessing the patient and the physical findings that we can discern from their thorax and lungs, we're going to use 4 classic techniques: inspection, palpation, percussion, and auscultation, okay? As we just spoke about their general survey, a first examination is going to be just observing the patient, okay? How are they sitting? Are they comfortably breathing while they're laying there? Are they sitting up? Can they, do they look like they're panting? Are they somnolent? All the above, okay? So Difficulty speaking in full sentences, like we said earlier, that is a huge sign for increased respiratory distress or impaired ventilation. Other signs are use of accessory muscles, supraclavicular retractions, or the tripod position. Okay, that's an easy test question right there. So vital signs and respiratory rate, we're going to carefully measure the respiratory rate by observing chest wall movements for patients with exertional dyspnea, conduct a monitored walking test to assess symptoms and oxygen saturation. So pretty commonly, preoperatively, we're not going to do this, but to discharge somebody home, sometimes they will. So it's good to know if you have a patient that, say, they're doing fine after their anesthetic, but they get up to walk to the bathroom, they desaturate, immediately become dyspneic. This could be a good way to assess how bad their O2 desaturation is. All right, so signs of systemic involvement are going to be hypoxemia or cyanosis, anemia. If they're pale, they just kind of look pitiful. You can definitely tell the anemic patients laying there in the bed. They look like they've had all the life sucked out of them. Extrapulmonary manifestations like clubbing, which can indicate chronic lung disease. And then how symmetrical does their chest move? All right, so evaluate the symmetry of chest movement during respiration for abnormalities that may suggest different lung pathology. So when we start talking about percussion, dullness on percussion may indicate a pleural effusion. So usually when we percuss the lung tissue, it's going to be nice and resonant. It should sound like there's air filled, not fluid filled, right? So percussion, dullness on percussion may indicate effusion or atelectasis, all right, while hyperresonance suggests conditions like emphysema, all right. Auscultation, we're going to listen for wheezes, crackles, rhonchi, and other abnormal breath sounds that could signal airway or lung parenchyma disorders, all right. We start looking at cardiac examination. We're going to assess for signs of right-sided heart failure like jugular venous distension, peripheral edema, and left ventricular dysfunction, signified by our S3 and S4 gallops and murmurs, which we'll get into that in our cardiac lecture. For abdominal examination, we're going to check for paradoxical abdominal movement. So that's inward motion during inspiration. That's that seesawing movement. So it just shows that they're having to pull really hard, and their diaphragm is kind of weak. All right. So examination positions, we're going to examine the posterior thorax and lungs with the patient sitting, and anterior thorax and lungs with the patient supine, ensuring appropriate draping for patient comfort. This is a big one, especially like if you work in a preoperative area where it's just PACU bays or a curtain that separates them from another patient. Ensure that you maintain patient privacy. That's a really big thing. I know we work in the OR. We're desensitized to all the things, but these people aren't. Make sure to respect their privacy. All right, so when we further look at our breathing observations, we're assessing rate, rhythm, and depth and effort of breathing, okay? Healthy adults going to breathe somewhere around 12 to 20 breaths per minute at rest. We're looking for abnormal breathing patterns like delayed expiration suggests COPD. They're breathing with pursed lips. We're going to review patterns like bradypnea, tachypnea, hyperventilation, Cheyne-Stokes breathing, and ataxic breathing. So signs of respiratory distress is anything with 25 breaths per minute or greater. Cyanosis or pallor, which indicate hypoxia or systemic conditions such as acute coronary syndromes or heart failure. Cyanosis indicators, you guys have all seen these. Cyanosis in the lips, tongue, and oral mucosa, which is circumoral cyanosis. Pallor and sweating are common in acute cardiac conditions as well. When we look at clubbing of the nails, it's going to be associated with conditions like bronchiectasis, congenital heart disease, pulmonary fibrosis, cystic fibrosis, lung abscess, and malignancy. Okay. I really like this chart and the way that it breaks down the actual patterns. Okay. I like the waveform because it jives well with our end-tidal CO2 monitoring and everything. It kind of breaks down on how these patients discerns your different Cheyne-Stokes breathing versus bradypnea, sighing respiration, ataxic breathing, all these things. I definitely going to be able to identify like Cheyne-Stokes and maybe ataxic breathing, okay? So another thing we're listening for is audible breath sounds, okay? If I can hear air coursing through a patient's airway without putting a stethoscope on their chest or airway, it's usually not a good sign, okay? We're listening for sounds like stridor, high-pitched inspiratory whistling, indicating an upper airway obstruction, which obviously stridor or severe stridor requires urgent evaluation and intervention. Neck observation. So check for accessory muscle use, the scalene muscles, sternocleidomastoid during inspiration, intercostal and abdominal muscles during expiration, and the tracheal alignment. That's a big one. So lateral displacement can indicate a pneumothorax, pleural effusion, or atelectasis. It also can indicate, if they have some sort of mass that is there around their airway. All right, so accessory muscle use is going to indicate increased ventilatory effort due to airways or parenchymal lungs disease. This can also, especially in kids, can lead to respiratory muscle fatigue. So the kids compensate until they can't, and then they crash. All right, another good one, chest shape. Okay, normally the AP diameter to lateral diameter ratio is going to be 0.7 to 0.75, okay, increasing with age. An AP ratio of greater than 0.9 may suggest COPD. It's that barrel chest that we see. When you see that and the patient says that they don't, see a pulmonologist, but they have chronic bronchitis, they always have a cough, they don't use inhalers, but they smoke a pack or more a day, and they have for years and years and years. They're short of breath, they have pursed lips, clubbed fingers, all these things, they have COPD. It's just not diagnosed. General inspection. So observe the shape, color, and symmetry of the chest, noting any abnormalities that may suggest underlying respiratory or systemic conditions. So the book does a great job of breaking down the different types of deformities of the thorax. So normal thorax here, we see that our lateral diameter is going to be greater than the AP. And then we start to look at our barrel chest patient, where our lateral is equal almost to our AP diameter. The next one down here is a flailed chest, signifying injury to the chest wall and potential pneumothorax. So we definitely want to, if we had a traumatic situation, we start to see this deformity, we're going to immediately think that lung that's under here is probably injured. A funnel chest or pectus excavatum, all right, so it's depression in the lower part of the sternum, can lead to compression of the heart and great vessels and may cause murmurs. So this is also, usually associated with congenital disorders. Pigeon chest or pectus carinatum, the sternum is displaced anterior, increasing AP diameter, and the costal cartilages adjacent to the protruding sternum are depressed. So you can see this pigeon-shaped breast. Birds, if you think about like a turkey breast, they've got a big sternum bone that comes out off the breastplate, so it forms a nice point there. Thoracic kyphoscoliosis, okay, when we get bad scoliosis patients, or say you're at Norton Children's and you're doing, a stage 6 out of 8 back surgery on this terrible scoliosis patient, the rotation of the spine can be so severe that it actually causes the ribs and entire chest cavity to change in its formation. So this is what we're talking about. You can see the curvature in the spine there. It spreads these ribs out, but collapses this side down. So taking this into account, and noticing this preoperatively is going to be, give you some foresight into potential changes that you might have to make to your anesthetic plan. All right, so as we spoke about with the anterior chest, the posterior chest, we're going to do the same thing, okay? With the inspection, something I want to point out here, unilateral lag in movement suggests pleural disease or phrenic nerve damage. There's a procedure that we do that commonly can affect the phrenic nerve. This is, used for pain relief, for anesthesia. So when we perform an interscalene block, sometimes that local anesthetic can get up high enough to capture that phrenic nerve. When you see this happen on a patient that has respiratory pathophysiology, say they have advanced COPD, or they're struggling to breathe, and you paralyze one side of that diaphragm, you can see somebody get into some pretty severe respiratory distress. I had a patient that was undergoing a shoulder scope. It was a younger gentleman that did have lung disease. He had some asthma and mild COPD, but most importantly, he also had anxiety really bad. So we did a interscalene block, ended up capturing some of the phrenic nerve on that side, and about 15 to 30 minutes later, we went back to go get him for his procedure, and sure enough, he was having a full-on panic attack because he could feel how hard it was for him to breathe with one side of his diaphragm being paralyzed. So definitely something to take into account there. It'd be an easy question on the test. So percussion for the posterior chest actually gives you a little bit more information than the anterior due to the lack of, other structures being there on the posterior side as compared to the anterior. You have, the heart, esophagus, trachea. So percussion may give you a little more information when we're doing this from the posterior side. This is all technique and things that if you don't remember how to do this from nursing school, I suggest you review this. Won't be any specific questions over it, but on the next slide, we have your pattern that you need to go through to capture all the different lung fields, but most importantly here, the percussion notes and their characteristics, okay? It's an easy test question over any of these. And if anybody has any questions on like how to find like something that sounds exactly like, that's flat, that's dull, that's resonant, that's hyper resonant, that's tympanic, just ask me during class or during simulation and we can give you some examples or show you. All right, and finally, auscultation, okay? So something that we should be very familiar with. Obviously, we know auscultation is going to assess the airflow through the tracheobronchial tree by listening to the breath sounds, adventitious sounds, and when needed, voice transmission through the chest wall. So before auscultation, we want to ask the patient to clear their airway, but most importantly, the stethoscope goes directly on the skin, okay? If we're performing a legit pulmonary assessment, stethoscope goes on the skin, not over a shirt, not over a gown, on the skin, okay? This is extremely important. So we're going to use the diaphragm of the stethoscope to instruct the patient to breathe deeply through an open mouth. You guys know that. Symmetric areas of the lungs using a ladder pattern. Listening to a full breath cycle, inspiration and expiration at each location. All right. On the next slide, we're going to have a little bit more of a description of the sounds that you may hear and what they may mean. So we've got vesicular sounds, all right, so they're inspiratory sounds that last longer than expiratory sounds. They're soft, relatively low, and you're going to hear these over both of the lungs mostly. Bronchiovesicular, they're intermediate pitched, often in the first and second interspaces anteriorly in between the scapula. Bronchial sounds, you're going to hear, they're loud, relatively high pitched, and over the manubrium or the larger proximal airways. All right, and then tracheal, obviously you're going to hear that over the trachea and in the neck. They're very loud and they are relatively high pitched. All right, so when we start talking about adventitious breath sounds, they're going to be abnormal breath sounds such as crackles or rails, wheezes, rhonchi, and pleural friction rubs, okay, that are superimposed on a normal breath sounds These can indicate pulmonary or cardiac conditions. So crackles or rails are discontinuous, intermittent, non-musical, and brief sounds like dots in time, okay? You can have fine crackles or coarse crackles, okay? The fine crackles are soft, high-pitched, and very brief. Coarse crackles are louder, lower-pitched, and slightly longer. All right, so the cause of crackles kind of varies. It may arise from abnormalities like of the lung parenchyma, like pneumonia, interstitial lung disease, pulmonary fibrosis, atelectasis, and heart failure, or of the airways, bronchitis or bronchiectasis. For wheezes, I want you to see that they're associated with narrow airways like in asthma, COPD, or bronchitis. Bronchi may change with or clear with coughing, so usually caused by secretions in larger airways. All right, so we want to note the characteristics of crackles. How loud are they? What is their pitch, the duration, whether they're fine or coarse. Are they fine, late inspiratory crackles that persist? They're going to suggest abnormal lung tissue. Change with cough or position. So crackles, wheezes, or rhonchi that clear after coughing or position changes often indicate secretions. Persistent crackles suggest more of a significant lung abnormality. You can also have a pleural friction rub, so it's a coarse, grating, biphasic sound typically heard during expiration. It's caused by inflamed pleural surfaces rubbing together. You see this in pleurisy, pneumonia, or pulmonary embolism. A silent chest can happen when you intubate the esophagus or in severe asthma or advanced airway obstruction, so airflow is minimal, leading to a silent chest, which is obviously an emergency. Okay, so stridor. You're going to hear a lot about this, especially when we start talking about like epiglottitis and things like that. But stridor is a high-pitched inspiratory sound originating from the neck, larynx, or trachea and is loudest over the neck, helping to distinguish it from true wheezes or rhonchi. So stridor is going to indicate an upper airway obstruction and requires urgent evaluation. All right, so remember this is an upper airway sound. All right, so transmitted voice sounds is an assessment that you don't really ever see preoperatively for anesthesia, but it is important to know how to do. Won't be any specific test questions over this, but I want you guys to review it. Egophony, you're going to ask the patient to say E. It's easy to remember. Normally it sounds like a muffled E, but if it sounds like an A with a nasal bleeding quality, then egophony is present. This suggests lobar consolidation or pneumonia. Then bronchophony, we're going to ask the patient to say 99. Normally the sound is muffled and indistinct, but a louder, clearer voice indicates bronchophony, which is often associated with consolidations and conditions like pneumonia. So whispered pectoriloquy is you're going to ask the patient to whisper 99 or 1, 2, 3. Normally whispered sounds are faint and inaudible. Louder, clearer whispered sounds suggest whispered pectoriloquy, which is another indicator of lung consolidation. So for the anterior chest assessment, it's a repeat of a lot of the stuff we talked about for the posterior side, okay? Nothing too crazy as far as remembering specifics, but just general assessment here. All right, same for this slide. Knowing what a pleural effusion would sound like. Like I said earlier, posteriorly, we get a lot more information from percussion because of the other structures that are there on the anterior side. This is a good detail to remember. For auscultation, again, you're going to use the ladder pattern, compare symmetric areas of the lungs, listening to breath sounds with the patient breathing deeply through an open mouth. The adventitious sounds is the same. All right, so when we start talking about lung cancer, it's going to be the second most diagnosed cancer and the leading cause of cancer death in the United States, okay, accounting for about 25% of all cancer deaths. Cigarette smoking is the leading risk factor, responsible for roughly 85% of the cases, followed by radon exposure, secondhand smoke, asbestos, and other occupational environmental factors. If you have a basement and you live in Kentucky, you need to get a radon test. Prevention. So smoking cessation is going to be the most effective way to reduce lung cancer risk. Risk increases with longer with smoking histories and higher cigarette consumption. Counseling and prevention strategies are going to be critical to reducing the overall burden of lung cancer. Early stage lung cancers have a 56% 5-year survival rate, while late stage metastatic cancers only have a 4.5% survival rate. All right. Most lung cancers are diagnosed late, unfortunately. So 16% of lung cancers are diagnosed at an early stage. If the patient smokes or those who have quit within the last 15 years, it is recommended that they get an annual low-dose CT, especially adults age 55 through 80. I'm not going to ask any of these specifics. It's just good to know for your patients. These are preventable things that we can maybe, educate the patient about, and they make a life change. We look at TB, okay, it's going to be 1/4 of the global population is infected with TB, leading to about 1.7 million TB-related deaths annually, and there's a huge outbreak right now in Kansas. In the U.S., 5% of the population has latent TB, but the prevalence is over 20% among the foreign-born population. So individuals with latent TB are asymptomatic and non-contagious, but they have a 5 to 10% lifetime risk of developing active TB without treatment. So risk factors, high risk is associated with individuals born in or residing in countries with high TB prevalence or living in high-risk settings such as homeless shelters or correctional facilities. All right, so we know the tuberculin skin test and the interferon gamma release assay, which is a blood test released, processed usually within 8 to 30 hours of collection. Either one of those are good screening tests. Screening guidelines. So the U.S. Preventive Services Task Force, or USPSTF, recommends screening for latent TB in asymptomatic adults at increased risk. Treating latent TB significantly reduces the progression to active disease. So the treatment risk, the primary risk of latent TB treatment is hepatotoxicity. The patients undergoing treatment should be monitored for liver function to mitigate this potential harm. All right, so sleep apnea is a huge one that we encounter in the anesthesia world, okay? So it involves repeated upper airway collapse during sleep, causing hypoxemia and disrupted sleep, particularly during REM sleep. All right, it affects 15% of men, 5% of women, ages 30 to 70, and it's often undiagnosed, okay? So OSA is linked to daytime sleepiness, increased risk of accidents, cognitive impairment, diabetes, cardiovascular disease, and all-cause mortality. All right, major risk factors. I would know this. All right, obesity, male sex, older age, postmenopausal status, craniofacial / upper airway abnormalities. All right. So usually a sleep study is done to diagnose OSA, okay, measuring brain waves, airflow, respiratory effort, oxygenation, and heart rhythms. We used to do a few of these with an ENT surgeon. We'd actually do an induced sleep study where you give the patient enough propofol where they fall into a deep sleep. Problem is depending on the provider, some people would get them sleepier too quickly, and they would actually obstruct due to the medications. But there's a protocol that you go by. You stair step the propofol up to the point where the patient starts to occlude their airway. The ENT surgeon goes in with a bronchoscope and looks and watches the airway collapse, and then sees how far they actually desaturate, which can be kind of nerve-wracking. Treatment is going to be positive airway pressure delivered via CPAP, bilevel, or BPAP, or APAP, okay? These are extremely important for our patients. If they have sleep apnea, it's recommended they bring them with them to the hospital, especially if they're staying the night. So treatment improves daytime sleepiness, airflow, and lowers blood pressure, but lacks sufficient evidence to confirm reductions in cardiovascular events or all-cause mortality. All right, so this is a great slide or a table from the book. So the stop bang test is a good way to assess your patient and see if they have sleep apnea. So if they answer yes to these questions or have these risk factors, then they're definitely going to be a high risk for having sleep apnea. Okay, I would know these as far as this stuff right here, and then I would be familiar with these questions. All right.